Gavin, thanks for being here.
Thank you for inviting me. Let's just load this. Um, okay, so I'm going to take us through a case, and I think the case just sets the scene for how we should approach choroidal tumors that are atypical in general. So this was a 55-year-old Chinese man, not much medical history, hypertension, dyslipidemia, quite expected for the age, had no systemic symptoms. He did, however, have a history of penetrating trauma with some surgery done when he was a child, so we couldn't get a great history. But we know that eye had poor vision and amblyopia since, but he was previously still able to make out 660, and vision had worsened over the last 1 to 3 months. So right eye vision was normal. The left eye was only counting fingers. In the left eye, there was an old cornea scar, which consistent with his history of ocular trauma. And in the left fundus, we see this large, pale, slightly hemorrhagic-looking, irregularly shaped tumor. And the tumor looked very vascular on a close-up clinical examination. And the other eye was unremarkable. The OCT showed some subretinal fluid, and it was pretty much a solid tumor. Does not look like a vascular hemangioma, for an example. So it was a solid tumor. Um, and the interesting finding, and I think B scan is always very important when we evaluate choroidal tumors. We know the classic melanoma description, which is low internal reflectivity. We know the classic hemangioma vascular tumor, which is the opposite end of the spectrum, where you get high internal reflectivity. Here, this tumor appeared to have to be kind of what I would say is biphasic. There was at the anterior portion, which had a high interior reflectivity, very bright signal, then a slightly lower internal reflectivity, almost but not quite an acoustic hollowing kind of appearance in the deeper layers. And that was consistent throughout the various cuts of the B scan. And the angiogram showed hyperfluorescence with a large amount of late leakage. The ICG didn't showed some vascularity, but did not have an appearance that suggested this was either inflammatory or or choroidal hemangioma in origin. So I think very often in atypical choroidal tumors, we think of whether it's melanotic, amelanotic. Melanotic, we would always think of melanoma first. In the amelanotic tumors, you still need to think of metastasis as the most common because that is the most common adult tumor that you will still find. But you need to think of the other differentials as well. In this case, as I mentioned, there was high to moderate internal reflectivity. It was quite a large tumor, height of 7 millimeters, base of 15 to 16, and leaking on an angiogram. So we were thinking along the lines, was this maybe a vascular tumor because of the vascularized appearance? There was a consideration, a capillary hemangioma, but it does not appear to be that kind of appearance. Because of the pale nature, could be an atrocystic tumor. Because of its nature of trauma, was this old granulomatous lesion. And of course, you did want to rule out Mets. I think this slide just gives a breakdown of what the appearance or differences would be for these other common tumors that we might find in the retina and choroid. And you can see B-scan tends to be very useful to distinguish melanoma from the rest. Angiogram is useful in delineating the vascular tumors, and so on and so forth.
Hey, Gavin,
Yes.
before you go any further, have you established or have you figured out is it a choroidal tumor, retinal tumor, or arterial?
So based on the B scan, we think it is a choroidal tumor because I think in one of the cuts you can see what looks like the overlying Brooks layer, and we thought this was almost like a pseudo collar stud kind of appearance. So it had a portion that was sub RPE, so in the choroid, and it had a portion that had penetrated Brooks into the subretinal layer.
Yeah, let's convert this ICG.
And as you can see in the ICG, there's an area of block senescence as well as an area of increased
And the disc is not
vascularity.
visible.
Yes, it's obscuring the disc. Correct.
It's not obscuring the disc, I mean, it's in the
Yeah,
disc.
it's involving the disc. And that's why at one point the differential that we're thinking of is this a peripapillary or an optic nerve tumor. That was a differential as well. So I'll go on. Any other questions, thoughts? I'll show a bit more imaging, then I'm gonna open it for differentials because this one was a very challenging case. So an MRI was performed, and we had a long discussion with our neuroradiologist, who felt very strongly it was a vascular lesion based on the MRI because of the amount of enhancement. The posterior scleral margin was well preserved, but obviously they always caveat that a primary malignancy needs to be considered and serial follow-up for growth. That's the standard radiology statement you tend to get. We also did a PET-CT scan just to ensure there were no lesions elsewhere, and other than an intense FDG positive lesion where that tumor was located, there were no other hypermetabolic lesions elsewhere in the body. The other investigations were all remarkable except for TB quantiferon positive. His MAN2 was negative, and he had no signs of pulmonary tuberculosis. So again, differentials and what would you consider? I was hoping to ask the panel what they would have considered to do in this case here.
I don't think there's any imaging test that will tell you what it is. So you have to have a tissue diagnosis. I mean, you can look at the B scan, you can look at MRI, you can look at anything you want. It's still going to tell you what it is. Suspect many things. And if it doesn't fit in anything particular, then you're really... That's my take on it.
Anybody else have an opinion?
Okay, we'll carry on then.
So we discussed the option with the patient. We were very keen on doing a biopsy, but again, because of the position, we know a biopsy is an invasive procedure, so the alternative was also discussed with the patient whether you wanted to serially monitor for growth. I think the patient decided he probably wanted a biopsy. That was arranged, and within a month, we felt the lesion was growing, and that was arranged about 6 to 8 weeks after the initial consultation. I don't have the full video, but what we did notice when we did this biopsy was the superficial layer was necrotic vascular bleeding tissue. When you went a little bit deeper, you ended up hitting what we thought was Brooks membrane. And below that, when we tried to get a deeper core, it looked like a slightly more pigmented tissue under Brooks membrane. And so we got two bites, one of the superficial and one of the deeper tissue. And that was the plan because we saw that kind of unusual biphasic appearance on the B-scan ultrasound. And the mass had grown even larger from the prior visit, and there was a much more extensive exudative retinal detachment. And at that time, we decided because we had to make a larger retinotomy in order to access the deeper tissue, and there was a lot of exudative retinal detachment. We filled the eye with silicone oil. We sutured all the sites and did, of course, cryotherapy on all the sclerostomy sites. This was the post-operative image. And this was the tumor block. And this first block, I think, was from was the deeper tissue, where it shows clusters of atypical cells with melanocytic origin. And most of the stains, S100, CD68, were negative. Ki67 proliferation index was really borderline. Our pathologist didn't really feel it was significantly raised. And just because of the quantiferon, we also stained for acid-fast bacilli, which was all negative. This is a zoomed-up area. As you can see, almost a spindle-like cell appearance. Not too much nuclear atypia. There's a little bit, and not much mitotic figures being seen either. And this was another area of the cellular regions. And most of the other staining was negative. This was the more superficial portion, which mainly showed necrotic cells, so that white vascular, much more soft tissue that we saw in the biopsy was mostly necrotic cells. And these were the staining, not too much significant. So I think the conclusion from this we felt was it was an atypical melanocytic proliferative lesion, and the call based on that core biopsy was likely a melanoma. So in this patient, I think in view that it was a melanoma, in view of the size and proximity and likely involvement of the optic nerve, and enucleation was performed, and the histology confirmed that diagnosis, and it appeared on the full histopathology that the superficial, that pale vascular area was a portion of the tumor that had breached Brooks membrane, and it had a lot of vascular congestion and necrosis, and which is why it gave us that very atypical appearance, that vascularity that seemed to trick us into thinking it might be a more vascular lesion rather than a solid tumor. Unfortunately for the patient, liver mets were detected 1 year after enucleation on his regular MRI liver follow-up. So I think in conclusion, this represents what you may typically see with amelanonic tumors. If there are features that confirm a diagnosis for yourself, then you would treat it as such. But if there is diagnostic uncertainty, I think a biopsy can be done, and a biopsy is quite a non-invasive procedure now. Often you can do it without too much issues or complications. But in this case, it turned out to be a melanoma, so the patient had to lose the eye. Any questions, discussion, or thoughts?
Very nice presentation. Thank you. So it's a further melanoma with optic nerve invasion.
Yes.
You can see some infection, you see optic nerve. The treatment is enucleation for that. Very nice case. Any questions or comments before we go to the next presentation on optic disc tumors, right? You're going to present on that. Continue on optic disc.
Okay.